So the title of this talk is Good Things Come to Those Who Investigate. During the course of this postgraduate day on video fluoroscopy, we will remember and explore the past, present, and future of imaging oropharyngeal and esophageal function during swallowing. So as we prepare to hear from the upcoming speakers, I want to plant a seed in your mind on the topic of investigation, specifically the advantages and disadvantages of being in a field that relies heavily on imaging to make decisions. So investigation requires us to examine, inquire, probe, and search. And what I'd like to impress upon you is that given the complexity of swallowing, imaging should be viewed as a means to help make the best possible decisions, but it doesn't always serve as a smoking gun that we'd like it to. So imaging is important, not the smoking gun, and I'd like to talk specifically now about how it's important, okay? So swallowing is a hidden function. So we use imaging to elucidate swallowing. Without imaging, in my view, we're being asked basically to do the equivalent of diagnose congestive heart failure with a stethoscope, or perhaps diagnose a stroke with phrenology. If we think about many clinicians who, despite the importance of imaging, do not have access to any form of imaging for their patients. And so in my view, as a field, we probably should begin to ask, what are the ethical implications of making critical decisions about an internal function that was never seen? Now, our field has many super clinicians. These are people with honed skills in dysphagia who are challenged with making critical decisions about their patients with only a screening, clinical bedside, medical history, and reports from the caregiver and the patient. But I would probably suspect that even these super clinicians probably feel that they would be better with X-ray vision. If we think about a related field that also deals with internal functions, I suspect that a well-trained otolaryngologist could take medical history, patient complaints, and just audio information and make pretty good differentiation between two broad categories of vocal fold pathology. However, if you have multiple layers of information, it helps to make the whole picture much more clear. And so that's what we're hoping to impress upon you with the use of imaging. So, in terms of how imaging is important, it enhances the investigation of internal functions such as swallowing. However, imaging is not always sufficient. Because with imaging, sometimes things are not always as they seem. So I'd like to talk about 2 or 3 limitations. The first thing is that we have a 2D to 3D conversion. So swallowing is complicated and dynamic. We have multiple things moving at the same time. And so it's possible that given that with video fluoroscopy, we are seeing less than 50% of the picture, considering that the sensory component is not even represented at all. So even super clinicians with 2D X-ray vision then needs to extrapolate to a 3D environment. Another limitation is that sometimes we focus on the obvious. And so what usually means is that we focus on aspiration, right? It is the most salient thing that we can see in video fluoroscopy, and it's often the thing that we're trained to take note of. Now, on one hand, it's great that the thing that we're trained to focus on is easy to see. Oftentimes, after we have identified aspiration, we're left saying, now what? Which leads me to my third and final limitation, is that imaging does not always allow us to decipher the layers of causation. And here's what I mean by that. Let's say aspiration is clearly on the surface of something, okay? We use video fluoroscopy, we can clearly see aspiration. There are still a number of layers, even if we decide the immediate cause of aspiration that we need to go through before we can probably figure out what the cause of that particular thing is. So perhaps in a patient, delayed onset of the pharyngeal swallow was clearly the reason why they aspirated. And we might say, well, was there a sensory loss? And if there's a sensory loss, well, could there be some problem in the peripheral level with innervation? And if that's the case, perhaps we could go deeper and say, well, is there something at the level of the brainstem nuclei or perhaps the cortex? So when we look at layers of causation, aspiration is really just at the surface, and there are multiple layers beneath that we probably need to consider if we're really getting to the cause. Now, the good thing about imaging is that sometimes what's on the surface clearly represents what's expected inside, okay? And that can sometimes be in the case of when bolus flow sort of outlines some structural difference that can allow us to sort of extrapolate and think, I think I know what's happening on the inside there. On the other hand, sometimes it's not so clear what we're looking at, okay? So we might see something like this. And in the case of head and neck cancer, not only is physiology different, but anatomy can be vastly different than what we're used to looking at. So some of you might be saying, well, why can't we focus on bolus flow without investigating the layers of causation, especially if we're going to all end up deciding on the same treatments anyway? Well, in my view, this is not just a case of you say dysphagia, I say dysphagia. I think it really is something that we should consider. And here's what I mean. This is my view of a practical example. So in the event that you're in your house and you realize, oh my goodness, there's water damage. So you hire a specialist to look deeper and say, that person says, yep, there is in fact water damage at a deeper level. But then the contractor leaves without detecting the source of the water damage. Perhaps if we look deeper, we might not always get the exact cause, but if we try to identify some physiology associated with the reason for diverted bolus flow, perhaps our treatments might be more targeted. So in the case when a patient coughs, we are asked to look more deeply and see whether or not there's aspiration that is the reason for that cough. And further investigation should be for the cause of bolus flow. That is because aspiration is bolus flow. Bolus flow is not physiology. Bolus flow can infer physiology. Bolus flow is subject to physiology. So physiology should determine treatment. And that is because, simply put, physiology is in charge. The bolus can't karate chop its way into a closed larynx. So imaging is an important tool for deeper investigation of swallowing, and it may be insufficient for fully understanding swallowing physiology. So as we go through this postgraduate day, I hope that all the upcoming talks will help us to think about imaging as a tool for investigation, to help us to think more deeply about physiology, to help our patients. Thank you.
I am the one that probably started the speech-language pathology revolution into dysphagia and what I've called the modified barium swallow, or in my facility, 1,000-bed acute care hospital, the cookie swallow tech. In 1970, I was hired to study Parkinson's disease, speech changes, at a time when levodopa was coming on the market. Patients were coming in the hospital for 3 or 4 weeks. Isn't that a revolution? They were washed off of their old drugs and placed on levodopa. They were very sick. And what I realized in the first year of my job was that these patients, you will understand this, some get angry when I say it, patients didn't care about their speech. They wanted to eat. They could not swallow, and they were desperate. So I went to the chair of neurology, my boss, and he and I talked, then went to the chair of radiology and sat down and said, we have to design a test for swallow function in the oral cavity and pharynx. And we did. And for a number of years, I did the test with the chair of radiology. And it was a very simple test because these people were very sick. They had no medication for a period of a few weeks, and we didn't know what L-DOPA was going to do for them. So we gave them 3 swallows of 1 ml thin liquid, 1 ml pudding, and 1/4 of a barium cookie. Thus the name, the cookie swallow test in my hospital. And we kept with that test for quite a few years. Then the questions we were trying to ask were very simple. Does the patient aspirate? When? Before, during, or after the swallow? Why? What was their response? Did they have a sensory recognition and were able or not to clear material? Then, did the patient have residue? Where was it? Why was it? And again, what was the response? Because the thing to keep in mind that we don't emphasize enough is that there is tremendous sensory information coming from a VFSS or an MBS, whatever you want to call it. Well, as we and a number of other labs started to study normal swallow, we realized there was great importance in looking at volume changes and how the mechanism handled those, whether it's a normal or an abnormal patient, what the viscosity changes caused in the swallow, and what was aging doing. So we built a large amount, and by we I mean others in this field besides myself and my lab. These were sequentially important parts of understanding the normal and abnormal mechanism. Therefore, we changed the test. I've actually had people say, well, where's the protocol? Well, it's been published for 20 years in varying forms as we've developed it, at least the one that I put together. And so the second version, which was in a manual that I've published twice, and the third edition will be out in another 9 months, we changed it 2 to 3 swallows of 1 ml, 3 ml, 5 ml, 10 ml, and free cup drinking of thin liquid. So we could understand, is this patient's mechanism shifting normally with volume or not, and what is the disorder? Then 2 to 3 swallows of 3 ml pudding, and 2 to 3 swallows of 1/4 of a Lorna Doone cookie. Sometimes people say, do you own stock in Lorna Doone? No, I do not. It is a cookie that can melt in the mouth, that can be crushed, so you can look at how patients with poor tongue function, oral tongue function, manage the chewing and manipulation before they swallow. So that became the second version of the protocol, and we have learned a great deal about that. Here we're looking at gender effects. There are differences in women and men, how we swallow, how we protect the airway, and gentlemen, those differences may account for why you get pneumonia when you get older more than women do. Age. We know aging changes swallow. We have to look at norms relative to their age when we look at the x-ray. And what is their medical diagnosis? We, as SLPs, don't make a diagnosis, but we certainly will say, this patient swallows like one with Parkinson's disease. Get them to neurology. Neurology evaluates and tests and diagnoses. Same thing with other, particularly neurologic problems. So there's a great deal of information that we get from the MBS or the VFSS or the cookie swallow, whatever makes sense to you. Now, most recently, we have expanded beyond evaluation to treatment. And I believe if you don't include treatment, you are selling your patient short. And by treatment, I mean, first, if the patient aspirates or has residue. For me, aspiration, telling me they aspirate tells me nothing. You must tell me why. You must tell me what you did about it. Because our goal is never to make someone non-oral. It is to define the treatment effect that allows them to eat at least something during that x-ray. So they roll out of that x-ray room with the data efficacy for a particular treatment. The days of our seeing the Parkinson, the ALS, the stroke, the head-injured patient are gone. We have gone up 10% 1 year in people 80 plus years old. These are people with 5 or 6 diagnoses. You cannot look in the literature. I have clinicians emailing me, well, I couldn't find anything about my patient. He had a cardiac problem. He had a respiratory problem. He had a blood problem. And you've got 5 diagnoses. You're not going to find your patient. You have to make the MBS a diagnostic treatment study. So you have the efficacy for that patient from your study. Oh, maybe it makes the x-ray longer. 1 minute at most. We can do 3 or 4 treatments with a patient in X-ray during the MBS and come out identifying what treatment works for them. There's your efficacy for the third-party payers that want to know, well, how long? Where are we going with this? Can this patient eat? Because eating by mouth is a heck of a lot cheaper than all the non-oral feedings that you can think of and all these odd forms of liquid, etc., which we've studied and have a place, but they're not the first place for me, and they're not the first place for the patient. Look at the compliance data. Patients don't like them. Our job is more than diagnosing, but it is also treating and defining efficacy. So we have to know, as the slide says, why are they aspirating? Why do they have that residue? What's causing it physiologically? I think Inessa, Dr. Humbert gave a wonderful introduction to this. We are physiologists. We have to be. So, what can be done immediately to eliminate the symptoms and facilitate oral feeding? If nothing, why not? There are patients, severely demented patients, for whom nothing but changing diet, and even that may not work. But you document that in a report, and I will introduce in the order a posture change that I believe will work, a sensory enhancement that may work, a voluntary control, or what we've called swallow maneuvers, and then last, only last, diet change. Okay, so your report should include aspiration and residue, which are symptoms. They're not disorders, as we know. Swallow disorders causing those symptoms. The reaction to aspiration and penetration. The sensory part of this, and I'm making it a separate paragraph in my reports. Does the patient recognize it? What's the normal response to residue? You immediately dry swallow. Does the patient do that? Or do they sit there? And the tendency as the clinician is always go, swallow again. You can't do that. You have to wait for that patient to respond. Try your interventions, then make your therapy recommendations. Do your oral feeding, non-oral feeding, and the timing of when you might want to see that patient again. That's what I call a good MBS or VFSS report. And I am very sad to say I see a number of them, whether it's from a physician, a radiologist, or an SLP, patient aspirated, do not feed. That is a waste for your patient, a waste for you, and the clinician who's going to pick that patient up afterward because you've told the clinician nothing about how to proceed. Well, here is a bunch of references, but my point today is to say, with a very little more increase in X-ray time, you can expand this test to where I believe it needs to go. And that is, what's wrong physiologically or anatomically, and what do we do about it? Because the literature is not going to help you to find that 95-year-old person who has 7 diagnoses, and here's what you do about it. It's not there, and it's not going to be there. We have to make that literature, and I challenge you to do that. I'll stop.
Thank you very much for these illuminating talks. It's really an honor to have all of you on this panel. So we've prepared some questions. These are sort of the questions that we'd like to ask, but maybe are afraid to, and maybe afraid to answer and be honest with ourselves in some ways. So I will start with Dr. Logeman, and we are wondering, in what ways have you seen the field improve with the widespread use of a modified barium swallow study?
Well, that's a difficult question. I see a lot of patients. I still see patients every week, and what I see are the difficult ones that people refer or who are desperate. And when I look at reports, it's highly variable. I see people, and Dr. Palmer brought up a wonderful point, and that is that say, patient failed, don't feed. It's meaningless. You could just throw the money away. It hurts me. And we will, right there in X-ray, make them able to swallow something. And you all know, I'm sure from your experience, how grateful patients are. So I still see too many reports that say pass, fail, and that are totally unacceptable. If that's all you can do, don't bother, because you will delay a patient, you will hurt a patient. And that's true of all professionals. I see it from radiologists. They turn off the x-ray the minute someone aspirates. That's absolutely unacceptable. So it's not my field, it's everybody. We have to go past this. So I see improvement, and great potential, but I have concerns. And part of those concerns come in the teaching of dysphagia across all professions. I really thought when ASHA made dysphagia a requirement of the 10 areas you have to have coursework in, we'd see an improvement, but we're not, because many, many universities don't have money to hire someone who really knows the area, and they hire someone who doesn't know it well, and that hurts me. And I've talked to others who specialize, as I do, in dysphagia, to have the same thing. So I see, I'm being honest, pluses and minuses in every profession involved. And I say to my students, if you don't love this area, if you don't know it well, get out, because you will do more harm than you do good. And I'll say it to you.
Thank you.
Sorry. I wish I could say it.
And so this is for all three of our clinicians, scientists, and it's piggybacking on this question. So I guess it's a two-part question, and you partially answered this. Do you think that most clinicians out there practicing are truly skilled enough for adequate interpretation? And if no, what can we do to really start training people appropriately to be proficient in this field?
The question was to me.
For any of you.
You answer.
I think the issue is that there's a disconnect between what Dr. Logeman said, which is what is taught in the coursework and what is expected. I think that video fluoroscopy doesn't have a direct connection oftentimes to the treatments that are given. The treatments tend to be based on some physiological change, if you're doing supraglottic swallow or something like that, but it doesn't necessarily mean that the clinician has to know which muscles are responsible for that maneuver. And so as a result, when sometimes when the treatments don't match the knowledge of which cranial nerves or which muscles are in charge of it, it's difficult for you to change course if something changes. And sometimes I get comments that, well, we don't have that many treatments. And I guess my response to that would be that if you went in with a stroke and somebody did like phrenology on your head and said, I feel a bump here, I'm gonna, I don't know, do something else, and they said, well, we don't have that many treatments, you would hope that they'd use their medical knowledge to say, let me think about your case individually, let me do something that can be maybe targeted to you. So with that disconnect, I think that it makes it difficult for clinicians to sometimes put the physiology with the radiological symptoms.
I really think our education in this area across every profession, whether it's physicians, specialists, whatever, and SLPs, isn't what it needs to be. At Illinois Speech and Hearing this year, Jim Coyle gave a talk, and he said something that I hadn't thought about this way. He said, think about the name of the course we as SLPs learn in anatomy. It's anatomy of the vocal mechanism. What does that say about our profession's recognition of the fact that vocal mechanism is the least important thing we do with this mechanism? This mechanism, the upper aerodigestive tract, does three things, two of which are critical to life. One of which is breathing, the most critical. The second is swallowing, the second most critical. And then there's the speech that man has added onto it. But the very fact that we have not recognized in our profession that the name of that course should be Anatomy and Physiology of the Upper Aerodigestive Tract says a great deal. And I congratulate Jim for raising it.
If I can make a comment on that too, Jerry. I've often had patients say, why do I need to see a speech language pathologist. There's nothing wrong with my speech or my language. So maybe we should be thinking of another name for the specialty, especially if we are involved in swallowing. So that's sort of... The other thing I think is there's so much to know nowadays that it's very hard for even someone who's specializing in a small field to keep up.
I agree.
It's very, very difficult to teach all of that because things are moving so fast. And the other thing, I think, is unfortunately our present tool, one of our present tools, to my mind, the gold standard, but I'd discuss that if you want to.
I don't disagree, but I know the limits. I agree.
Right. Isn't sexy.
No.
It's not sexy to a lot of radiologists, for example. They'd rather be doing MR of the swallow, and you'll see an MR of swallow abstract from our institution. That appeals to people, right? Whereas video fluoro,
That's the old stuff.
Right, it's gone. It's no longer sexy to people. And we have to make swallowing, and we have to make the evaluation of swallowing by video fluoroscopy sexy.
Do you have any concrete recommendations for that?
I have sometimes joked, come in my lab, you'll see the nude larynx.
I don't think I have any real suggestions. I don't think we should come along in short skirts and low tops. But they certainly wouldn't protect us from the radiation. But somehow we have to think about how to do that.
Sure.
Hi, I'm Jan Lewin from MD Anderson Cancer Center. Fabulous panel, and thank you very much, all of you. I think there are two comments that I'd like to make along 2 points that all of you have made. First off, as a profession, in terms of lobbying for our services, I don't know that we do such a good job.
We do a terrible job.
You know, my concern really is you'd expect, and with all due respect to people that are older in the field who don't have a good appreciation for swallowing and aspiration and what causes it and what we should do. I understand that. But I'm in a world-recognized institution, and the kids, that's not nice, the young MDs, primarily, coming out of school are still uninformed, are still talking pass and fail, are still being taught stupidity. Sorry. So I wonder if some of the efforts of this society shouldn't be at or aimed at helping to, and again, with all due respect to my medical colleagues, the leader of the team is always, in most rehabilitation places, most hospitals, the MD. Why are we not pushing, or are we, coursework and courses being done at the level of the medical schools so that this information is disseminated in a much more academic and much more critical, important way? That would be my first question to the panel. And then the second thing that I struggle with, and I'm sure everybody in this room is struggling with, is the push, the mandate to bill the services, bill. So what we see happening, and again, something that disappoints, really hurts me, is that when you talk about people not thinking or critically evaluating, what you see are people who are being given tools out by the manufacturers, by people who aren't swallowing pathologists, but they're tools that the insurances pick up and say, wow, you can bill it, so everybody's doing it without any thought of efficacy. Mm-hmm. So I'd be curious as to what we can do. I mean, we talk a good game, but what can we do to make this better?
Thanks. That's an excellent point. I'll put that to the panel.
Well, I think one of the things you may be pointing out is electrical stim, which has been sold to our profession and every other physician profession with no data to support that it works. If you're interested in that, come to the results of the large clinical trial that Susan Langmore was the PI on. I was involved in my lab with it, and you will see what it does or does not do for head and neck cancer patients. That's one population. What I find is clinicians will say to me, and this is true of the docs, as well as the SLPs, the PhDs, well, usually the MA clinician or the physician, well, I don't really have research expertise, so I can't evaluate it. Well, yes, you've got common sense, folks, and you should have good basic knowledge. And when something makes no sense to you, I'll throw out something else. That laryngeal analyzer that was sold for years, which had absolutely no data, for which many of the scientists in swallowing offered to study and never were sent one because no one was going to spend $25,000 on a piece of nothing. But there were 6 or 7 of us that all offered to study it free of charge. Finally, the Swedish group did and found there was absolutely no efficacy. But some of you came to me and said, this makes no sense to me. If it makes no sense to you, it makes no sense. Don't spend your money. And why people jump on these things, it makes me crazy. Folks, there's no miracle here. If there was a miracle, we'd have all found it a long time ago. And be very cautious and use your common sense.
So I'd like to also just address the important second point that Jan brought up, which is what can we do in terms of education? So we have didactic courses in speech-language pathology and clinical fellowships, but when we're training physicians, otolaryngologists, radiologists, other rehabilitation, physiatry, et cetera, what could we do differently to really ingrain this in our training?
Can I speak to that?
Yes.
Because in many medical schools, the training physicians are not exposed to radiology, for example, at all. And it is not a required course at Hopkins, but the students actually fight each other over coming to radiology because it's the most popular course. And what I find is they all want to come down and watch fluoroscopy for half a day. And they come down, and I can see their eyes getting bigger and bigger and bigger, so that by the end of the day, they all look like they're thyrotoxic. But a lot of the physicians are not taught, what is an upper GI? How does an upper GI different from a swallowing study? How is an upper GI different from an upper GI with small bowel follow-through? They don't even know what symptoms should make them order the tests. And every day when we're doing our studies, I have a room that's just doing swallowing work, and I have 2 other rooms that are doing other fluoroscopic studies. I would say we spend 20% of our time on the phone talking to the clinicians and end up changing whatever study they've ordered. So that they're not being trained with, connecting the symptoms with how to investigate the symptoms. So somehow we have to rethink the training process, certainly for physicians, which is really all I can speak to.
Thank you. Teresa.
Hi, Michelle. Hi, everybody. Teresa Biber, Broward Health, Imperial Point. Of course, preaching to the choir, as you guys have done, and when I come every year to these meetings, I'm always inspired to go home with something that's going to help me understand my patients better and to give them a more appropriate treatment. That said, back to this whole concept of the lack of standardization in reporting on the modified barium swallow. And we know this has been an issue, and I know Bonnie Martin Harris has worked very hard in trying to establish, different things you should look at. But how hard really would it be for us to create an ASHA-approved and DRS-sponsored or certified or whatever form that just addresses the fundamental things, as Jerry talked about in her talk, so that each one of those things has to be looked at by a treating speech pathologist, and anything less than that is not acceptable. So you can no longer write plus or minus aspiration. You have to say why the patient aspirated and what you did to prevent the aspiration from reoccurring. It just doesn't seem like it would be that hard to do. You can't mandate it, but you could certainly strongly suggest. And as we move into an era where healthcare is changing rapidly, and if our goal is simply relegated to can the patient eat or not, quite frankly, a radiology tech could probably be trained to do the same thing. Honestly, they aspirated, they don't aspirate, feed them, don't feed them. And that's a lot of what's happening in our field with just a speech pathologist who's not well trained and well versed. So it seems to me there should be maybe a stronger certification program for doing swallow studies, a basic fundamental training course that you have to document, and then some sort of a form where you're addressing all of the important issues that are needed in accurately reporting a modified barium swallow. Just an idea.
Well, actually, we're doing it right now.
Well, great.
We're putting together what I'm calling a cheat sheet, which says they aspirated why. This is what it follows the report. What did you do about it? And then lists the things you could do by disorder, symptom that you see, and then goes into other things. Now, the other thing I forgot to say, and I really want to, is there's a subcommittee of us, including Jeff Palmer, Peter Karillis, as well as SLPs and others, we've put together a questionnaire. It's a survey. It's on the listserv, not the SID-13 listserv, but the other dysphagia listserv, because ASHA doesn't want certain things on the DRS listserv. But anyway, it asks how people are doing the MBS or the VFSS. So we will have a picture, and we've got over 300 people who've taken it. It's about 50 questions long, but it only takes about 20 minutes. And it will give us a really good picture of how people are doing the VFSS, what foods, why, a couple of questions about what would you do about this problem or that problem, looking at treatment. And we're putting that results together for the submission for ASHA paper. So in November in Chicago, we hopefully will get accepted, and you can come and hear what we want to learn, and that's what is the variability in how people do the MBS or the VFSS and why, so we can really see perhaps areas where we should educate more or other things that we should emphasize. So thank you, but we're on the way to doing that.
Excellent.
So please take the questionnaire if you haven't, the survey.
Yes, and attend that talk as well. And attend the talk as well at ASHA.
Within Washington State, within the last year, we have a couple new fees companies that have moved in, and one of the bigger marketing pushes says that the MBS isn't the gold standard, and I'm just wondering what the comments are from.
They're saying it's not a gold standard?
They're saying that it's not the gold standard.
What do they say is?
Well, they're comparing fees to be like equal with the MBS.
You want to talk about first?
So I could jump in here too, which is that we actually have an entire session dedicated to fees, and I think that would be a great format to entertain these kinds of questions as well. We can speak about some papers that have been published talking about the concept of gold standard and things like that too. So I'm going to respectfully defer your question to the fees and move on to Dr. Kramer.
Yeah. Thank you. Julie Barkmeyer-Kramer from UC Davis. I want to compliment the panel. This was really an enjoyable session, and I want to jump on the comments about education and training. And as somebody who taught for 14 years the Dysphagia Graduate Clinical Training Program at the University of Arizona, I think I can speak pretty knowledgeably to the challenges in our institutions where we're mandated to teach at a graduate level, and one of the shortcomings for the one area of our field where a decision we contribute to the team might actually cause a fatal outcome. We've instituted no minimum competencies, and I see that as a big challenge, along with medically based training in general. So, along with dysphagia, there's trach and vent care. If you're going to do anything with electrical stimulation, you better know about circuitry and electrical signals and how they work and what's really useful with an electrode, how can electrodes work, and so forth. There's a lot of knowledge not being trained to our graduate students. And one of the biggest epiphanies I had was the year that I incorporated teaching the oral mech exam and adding to it additional cranial nerve testing. And the students said to me, I had no idea we were testing cranial nerves. So your graduate students cannot make that leap or bridge of knowledge themselves, and we need really well, competently trained individuals training them and making the bridge to the variety of patients they're going to see. I really fight the recipe-based practice, and I think you've all given a great example of how these are patients that we see who are so complex. And you cannot do a recipe with every patient you see. You have to have a working knowledge of the anatomy and the physiology and what information you need to gather in order to problem solve their treatment. And that's poorly taught right now. Our profession originally graduated 85% to the public schools, and currently the majority of our clinical fellow trainings are in the public schools, and then they go into a medically based practice. And HIPAA and other governing factors that limit access of our students' training in medical environments have actually created a barrier for our students to get into the hospital-based practice and have access to a variety of these kinds of patients. And so I think what we really need to start talking about are minimum competencies. What is the basic minimum knowledge base we want to train? Who's teaching it? And what are their competencies? And no more should we have our students in accredited institutions graduating from a 1-credit seminar where they had cleft palate, voice, and dysphagia, and that was what they got accredited for. Because those students aren't graduating thinking that they don't know what they're doing. And I think there was a survey by ASHA showing an inverse relationship between the amount of training somebody has in dysphagia and their confidence in the clinic. So the least trained you are, the more confident you are, you know what you're doing. And we all know that the more we know, the more we feel like we don't know. So that's what I tell my students, if you're afraid by the time you end this class, I have done my job. So I think we need to be thinking more in those terms of, do our 2-year programs really do it? Do we need to add an additional year to incorporate medically based training so that they actually acquire competency? And what are those minimum guidelines like? And I'd be very interested because Dr. Logeman was very instrumental when I was training back in the 80s. I attended the very first of these meetings, and I have to say my eyes were wide open, and she was very instrumental in really bringing the medically based practice into our training programs. Thank you.
Thank you. We have time for one more brief question. I didn't see who was up first. I think this gentleman was up here.
Coach Takahashi, oral surgeon from Tokyo, Japan. And I learned a lot from Jerry Logan textbook. I translated second edition of your textbook in Japanese. And my question is very strange. And today's video fluoroscopy is very classical for me. For example, movies. Today's movie is 3D, but video fluoroscopy is just silent movie. So, in our hospital, I recorded appearance of patients during video fluoroscopic study and combined VF images and sounds recorded from neck and respiratory sound and swallowing sound. And how do you think about future video fluoroscopic image? Future. I don't know.
Future. I've been very frustrated by the fact that video fluoro is a 2-dimensional technique. There are 3D fluoroscopic units that are used primarily in interventional work. But what I would really love to do is do a series of patients, normals probably to start first, and compare the video fluoro with a 3D MRI. And then we'd know exactly what muscle was moving to produce this appearance on the video fluoro. And we could perhaps combine it with oblique images for our video fluoro, which would give us a pseudo 3D appearance. So I think there's a great possibility for someone to make a great contribution to the field if we could figure out why the bolus does that, why it's deformed in a certain way, why it moves in a certain way, and then perhaps we could apply this to our patients, perhaps our head and neck cancer patients who've had certain parts of their pharynx taken out, and perhaps we could improve their physiology by knowing which muscles are producing which appearance. I think that's a very exciting field.
Yeah, I agree. We did one study, but it was very simplistic in the heart station where they used the 3D very much. Let me just say something. Be very careful about studies that compare what two different procedures do. I can give you 5 or 10 studies comparing fees and X-ray and MBS or VFSS. The fact is they're comparing on whether there's aspiration or not. They're not comparing on the why. They're not identifying all the other structures. So be very careful, because whether there's aspiration or not is a virtually unimportant question. And I will tell you, if you want to know what each procedure sees, we have 2 articles in Folia Phoniatrica, the International Speech Language Hearing Journal, that look by ENTs at what you see in every structure on fluoro and X-ray taken simultaneously. Doesn't talk aspiration. It talks about what movements do you see. So don't fall for studies that look at, well, they both equal in deciding if someone aspirates. So what?
Thank you, and I'm going to lose my job as a moderator if I don't get us off the stage right now. So I wanted to thank their very thoughtful questions and the participation and our outstanding panelists. Thank you so much.